This is Dave Meinhardt at the Vattikuti Foundation. I want to welcome everyone to our global webinar on blood and urine. Is it an alarming symptom? Our moderator today is Dr. Mahendra Bhandari. He's the CEO of the Vattikuti Foundation and just an incredible person. I've been working with him for almost 10 years, and it's really been amazing to see all the things that he works on. He works 24/7, I think, sometimes, as far as working on artificial intelligence and robotic surgery and many other facets of medicine that he's always working on. I'd like to introduce him as our moderator, and Dr. Ashwin Tamhankar will be our presenter. So without any more, let's go to Dr. Mahendra Bhandari.
Welcome everybody from across the globe. I see the names from outside the country also. I have a great pleasure in welcoming Dr. Ashwin Tamhankar, who is our alumnus for this webinar. First, something about Vattikuti Foundation and patient care activities. Vattikuti Foundation, since its inception, was focused on developing new technology to improve patient outcomes. And then we got as a necessity into surgeon education, because the quality of outcome dependent on the quality of surgeons. In recent past, we have become all-inclusive, and we start conducting educational program for the patient because we found a big gap in the knowledge of patient and the growth of technology. And this webinar is one such activity where we bring in the experts who can tone down their knowledge for the understanding of the patients. And Ashwin Tamhankar, who at least I know since for several years, he carries a great pedigree of urologist. For those who do not know, from Grant Medical College to Asian Institute of Urology and Nephrology, to working with, in 2016, with Dr. Gagan Gautam at the Max Hospital for his Vattikuti Fellowship. And incidentally, he was picked up by yet another international institute at Leicester in United Kingdom, which is also a Vattikuti Collaborative Institute, with Dr. Nikhil Vasdev, who is one of the very, very frontline uro-oncosurgeons and robotic surgeons. He did his fellowship there, and then he came back at the right place at the Apollo Hospital, Navi Mumbai. And I had the pleasure of joining the inauguration of this hospital, and I can see that what a wow infrastructure he's working. There's another message I would like to give, that these webinars are to improve the understanding of patient about their own disease. Because it is very essential that there is no gap between what a surgeon wants to convey to the patient, because we need a lot of cooperation of patients for their speedy recovery. And so please understand, hematuria is a condition, or we call the blood in urine is a condition which would scare a rustic as well as an expert. And we keep on finding simpler explanations for this, like, oh, it may be because I didn't take water, or it was because of this and all. One of the purpose of this webinar is to leave those judgment calls to your specialist, because he is going to tell you if it is how much you should be worried about it and how much you should really care about it. Second point Dr. Tamhankar will bring, that it is a very deceptive symptom. It's not a disease. Don't call people telling that I have hematuria. If your doctor has not given the cause of hematuria, still you are in their pending folder, because they are trying to find out the cause. It is a symptom. And the worst thing about this disease symptom is that it's an intermittent symptom. It comes and goes. So I have seen, and I'm sure Ashwin will bring in his talk, the patients who said, I had hematuria once, and then what happened? I know I never had it again. That is something very alarming because you may have blood in urine which you may not be able to see with your naked eyes. So it's a very significant subject. It is the origin of picking up major complex urological cancers, as well as it may be something which is to a very, very benefit of the patient to cure these patients from these symptoms. So without much thing, while welcoming Dr. Ashwin Tamhankar, I hand him over for this webinar.
Thank you for the kind words, sir, and I sincerely appreciate the efforts done by the foundation for basically it's an incredible journey so far being associated with the foundation since last 6 or 7 years. So I'm quite humbled to mention that I was the first Vattikuti Robotic Fellow with Dr. Gagan Gautam in Max, and Vattikuti Foundation supported all of us in India for getting into the fellowship programs to get trained into uro-oncology as well as robotics. And I can sincerely appreciate the tireless efforts done by everyone in the foundation, including Professor Bhandari. And so I think without wasting much of time, we will proceed for the talk. I've tried to make it as simple as possible for the benefit of listeners. So the topic for today is blood in urine. Is it an alarming symptom? Myself, I'm Ashwin Tamhankar. I'm a consultant in uro-oncology and robotic surgery at Apollo Hospitals, Navi Mumbai. So what is blood in urine? It is also called as hematuria in medical terms. It arises from a Greek word hemia means blood and uron means urine. So by definition, we need to find out RBCs or the red cells in urine to qualify a patient as a patient having hematuria. The description actually dates back to 496 BC when actually Hippocrates mentioned that blood in urine comes from kidneys and bladder. So it is not a new entity, absolutely. It's been well described since many years, and the cognizance of that is unfortunately not been taken by many of us till now, which is a harsh reality, and that is why we are here. But that is the purpose for having this particular talk today. So about the cause of the hematuria, it generally classified as medical causes, as well as the other part is geological or surgical causes. So medical causes can happen because of the diseases in the glomerulus. So just to explain about glomerulus, it's a functional unit of the kidney which forms leads to formation of urine. So it can have some medical entities related to the glomerulus, as well as certain non-glomerular events like vascular events or infarcts or problems related to the blood supply of the kidney, which may lead to blood in the urine. So we have to understand one basic concept, that blood in urine can only come from either kidney or the lining of the ureter or the bladder or the prostate and the water pipe or the urethra. So apart from these glomerular and non-glomerular causes, there can be possible causes symptoms which can be classified as tumors. So tumor basically is a cancer which can arise from all these four organs like kidney or the ureter, the bladder, prostate or the urethra, which may manifest with blood in urine. I'll be discussing about it in the next slide. Any trauma to the kidney may also lead to blood in the urine. So trauma may or may not be as in significantly higher, because sometimes you may have some anatomical abnormalities in the kidney. For example, swollen kidney. Even in that situation, even if a trivial trauma may be enough to inflict injury to the kidney on the lining system, and there may be blood in the urine. Another cause for blood in urine can be infection, which can be because of certain different organisms. In India, tuberculosis is a very common entity to be found out in the urinary system, and that may manifest with blood in urine. So strictures in the ureter, stone diseases coming from either kidney, ureter, or bladder may lead to blood in the urine. Previous history of radiation to the bladder, or collateral radiation damage to the bladder whenever it is given for adjacent organs like CS cervix in females, may lead to shedding of the mucosa, which may manifest with blood in the urine. And lastly, about enlarged prostate. Generally, enlarged prostate bleeds in a very late stage cancer prostate may not present with blood in urine per se directly, but this can be a rare occurrence in both non-cancerous as well as cancerous enlarged prostate. So coming to the cancers which we should be concerned about, nearly 85% of bladder cancer patients will have blood in the urine. So it's a significant number. Bladder cancer incidence is increasing. It's nearly ninth most common cancer in the world. The prevalence of a standardized incidence rates per 100,000 population or per lakh population would vary from about 1 to 15, and in India the incidence is slightly less, but in other countries or other parts of the globe the incidence is quite high, and smoking is one of the most important risk factors. So that is so blood in urine, bladder cancer, the first alarming thing which should be struck to the person's mind is to rule out cancers. That is one of the cancer, most important cancer is bladder cancer. And secondly, the kidney cancer. Again, the kidney cancer, these are the statistics from UK. The kidney cancer incidence did increase from a decade 1990s and till 2012. Now it has reached peak or plateaued, and slowly the incidence hopefully should come down by 2030. But in developing countries like India, the figures do mention that the incidence is still going to increase further till 2030. So these kidney tumors would manifest with blood in urine to the tune of nearly 60%, or sometimes pain in the flank, or pain or a palpable renal mass, which is classically called as a triad for kidney cancer. So just to summarize these few important causes of blood in urine, it can be either infection, it can be trauma to the kidney, it can be a cancer coming from bladder or kidney or urinary lining tract or ureter, or a stone disease. So broadly classifying, there are two types of bleeding in urine. One which can be seen to the naked eye, which is called as microscopic or a gross hematuria, and one which is unfortunately not seen to the naked eye, which is called as microscopic, which can be seen only under the microscope, and urine actually looks clear on the normal examination with the naked eye. So gross hematuria, even 1 ml of blood in the 1 ml of blood in 1 liter of urine is enough to be seen as a visible hematuria. Sometimes, rarely, some hemoglobinopathies or some bleeding disorders may manifest with these sort of symptoms. So hematuria, gross hematuria broadly can be classified as initial, which happens when someone starts to pee. The reason for that may be coming from the urethra or the terminal portion of the urinary tract, or it can be terminal, which may manifest with at the end of the urination, dropping of a few blood spots in the urine. That generally comes from the trigone or the collecting area of the bladder, or it can be a total, that is complete urine is mixed with blood, and it may arise from either kidney or bladder or any other upper tract. It may or may not present with some clots. Generally, the history is relevant. We do ask for it because we can assess a severity of bleeding in the urine. Whenever there are clots, that means the severity of the bleeding is quite high. And based upon shape of clots, we can probably have some idea or prognosticate whether it is coming either from kidney or it is coming from bladder, etc. Again, another factor which is important is whether the hematuria is associated with pain or without pain. So painful hematuria probably would be either more of because of either stone or say because of infections. But painless hematurias are the ones which should be most worried for, because they may be the first sign or symptom of any cancer coming from kidney or the urinary bladder. So microscopic hematuria, it is, like I said, not seen on the visual examination, as in whenever you're passing urine in on the pot, you may not be able to see that, but that would be seen and identified only by microscope by a pathologist. So whenever there are more than 3 RBCs per high power field, we call it as a microscopic hematuria. The sample, I've represented certain figures for the benefit of listeners so as to have adequacy or proper sampling. So generally an ideal sample for any urine routine examination or a culture is a midstream sample. So we need to discard initial 10 to 15 cc of urine initially. Better would be to have early morning sample as a freshly passed urine in a sterile container. We need to clean the local area. We need to take the foreskin back behind in gentlemen, and we need to clean the local area in females as well, so as not to have any contamination coming from the side. And the clean catch midstream urine sample should be sent for examination. So coming to certain statistics, nearly hematuria amounts to 20% of all urological evaluations. If you have 100 patients, nearly 20 patients coming to the urology clinic would be having a history of either gross or microscopic hematuria. And how much out of them would probably have a cancer? So nearly 10% of them will have a cancer. Nearly 13% of the patients with gross hematuria and nearly 3% patients with microscopic hematuria would harbor some kind of cancer in the urinary tract somewhere in the system. So the statistics from the British Association of Urology or the UK statistics do mention that 1 in 5 adults with gross hematuria, that is nearly 20% of the adults with gross hematuria, will have a bladder cancer, or a likelihood of having bladder cancer is quite high in these individuals, and 1 in 12 out of microscopic hematuria patients would probably have a bladder cancer. So, attributing a dedicated cause for a particular event, nearly 50% of gross hematuria candidates would be having certain dedicated cause to be, which can be identified on a battery of investigations. Similarly, unfortunately, microscopic hematuria, only 10% of these individuals will have a specific cause which can be identified based upon a certain battery of investigations. So, evaluation protocol, what are the aims of evaluating a person who comes to a urology clinic or a uro-oncology clinic with a hematuria? So first and most important is to pick up any malignancy or to minimize the likelihood of missing any malignancy. Second is to identify at-risk individuals so as to have a risk adapted strategy for them. Third is to rule out certain local causes. Fourth, most important, is sometimes, like I said, the hematuria can arise because of the problems in the glomerulus or the functioning unit in the kidney, and that would be the ideal time for a patient to be into a good follow-up with a nephrologist for long-term protection of kidney functions. So delay in identifying a bladder cancer, or for that matter any cancer, obviously has a very bad prognosis. Given that the percentage for bladder cancer, a delay would probably attribute to 34, or nearly one-third increase in the increase in the cancer specific mortality. So history and examination are most pivotal of any evaluation, not just hematuria but any evaluation. So in history of a patient who's presenting with hematuria, we are looking at age, we are looking at sex of the patient, because males have a higher chance of having cancer. History of gross hematuria, any history of previous urinary infections, fever, or burning in the urination. Simultaneously, we also look into the urinary symptoms, which we call it lower urinary tract symptoms, or LUTS, by which I mean the patient can have frequency of urination or urgency of urination, or sometimes incontinence. Patient may have to get up in the night time for passing urine. So these are the things which are looked into as a part of history. Along with that, history of smoking, history of previous medications or chemotherapy or radiation drugs, previous history of any malignancy in terms of family history of or genetic associations for any familial syndromes, and most important is environmental or occupational exposures, the reason for which I will tell you in subsequent slides. So examination after the history is important. Most important is blood pressure, because like I said, medical hematuria or hematuria arising from glomerular pathology would generally we have rise in the blood pressure, and that may be the subtle early sign to pick it up. Obviously, along with that, any bleeding disorders which can be picked up on general examination are important. After that, genitourinary examination to find out a local cause is most important. For example, in women, the per vaginal examination after certain age group is important, because you may have certain abnormality or cancer coming from cervix, which is manifesting as blood and which we are falsely attributing as blood in urine. So all local examination simultaneously in gentlemen, we need to examine for the prostate by examining the prostate through the back passage by inserting a finger, which we call it as a finger test or a digital rectal examination. So all these factors need to be the first pillar to evaluate a patient with a hematuria. So what are the battery of tests or investigations which are done for a patient with a gross hematuria? So most important is urine routine and urine cultures. Urine cultures would obviously rule out infections. Urine routine is generally somehow a test which is not attributed a lot of significance by many of the colleagues or many of the general people. But I think urine routine is the test which gives majority of the picture or a representation of a patient's health or patient's possibility of having any pathology is reflected in urine routine, by which I mean any abnormality in the glomerular tract or the lining of the urinary system may have alterations in the pH. if you have glomerular abnormalities, you would lose some proteins. So if the proteins are positive, you may think about having glomerular pathology. Diabetic patients would have ketones in the urine, and they would have blood in the urine because of an entity called papillary necrosis, which leads to which diabetes is one of the risk factors. Simultaneously, the nitrites and the leukocyte esterase would be positive in patients with infection. So all these factors are very relevant before proceeding for further management or evaluation. Simultaneously, white cells in urine would also be present because of active infection, or just completed infection would form pus cells or squamous cells. Not to forget red cells. The count of the red cell is important per high power field to prognosticate a patient or to stratify the patient, which we would be discussing later. In gentlemen, along with this, PSA comes as a pivotal part of hematuria protocol, because prostate cancer can rarely present with blood in urine. So next is urine cytology. I'm not going in details of it. It's a technical test done by a pathologist under the microscope. They look after, or they look for the cells, abnormal cells, or the nuclei of the abnormal cells to identify certain abnormal cancerous cells, which has a very high specificity. Generally, it is given for subsequently at least 2 to 3 samples consecutive days, and that gives fair correlation with possibility of having a cancer. CT scan is the next investigation. Any patient coming with a gross hematuria has to have a cross-sectional imaging to rule out any abnormalities. CT scan can give us information about stones. It can have little information about infections because of some haziness around the kidneys, etc. And most important reason for us to go for a CT scan in these particular individuals is to rule out cancers. So cancer coming from kidney, cancer coming from the lining of the ureter, and cancers coming from the bladder are classically seen on CT scans. In addition to that, any anatomical abnormalities in the kidney or the ureter can be picked up as well. So the next investigation is to actually look into the bladder of a patient, which is called as cystoscopy, or in simple language, it is called as a camera test. It can be easily done as an office procedure under local anesthesia, where a person undergoes a procedure in a very short span, and the bladder is completely visualized from inside to rule out any abnormality or a tumor. So this particular test would give us information about the water pipe or the urethra, the bladder, and prostate in gentlemen. So this is pertinent to gross hematuria. Now coming to the entity of asymptomatic microscopic hematuria, which we discussed, which no one can see on the naked eye, but which would be picked up only under microscope. So that would be picked up when someone goes for a routine health checkup, because normally every health checkup will have urine routine as the basic evaluation test for ruling out many abnormalities, and we are looking at red blood cells or the RBCs in these particular samples. So the urine dipstick is an easy test which can give us some information about possibility of blood in urine. Obviously, if the urine dipstick is positive, one has to undergo a dedicated urine routine microscopy to define or to identify red blood cells. Next is to identify at-risk individuals. So I'll be keeping this slide for a while, because this is the most important slide. So I would encourage everyone to probably go through this, because you need to identify yourself whether you are actually at risk of having any cancer if you're having gross or a microscopic hematuria. So the age more than 60 is very important factor. Gentlemen will have more risk than females. Smoking is most important obnoxious history to have. Any gross hematuria or microscopic hematuria which is recurring or persisting is important factor. Any irritative lower urine tract symptom, by which I mean increased frequency, urgency of urination, or nighttime urination, is significant factor as a risk stratifier. Any previous history of radiation or particular chemotherapy which is toxic for bladder may also have risk factors for qualifying patient for urothelial, for possibility of having a cancer. Secondly, any family history of urothelial cancers or occupational exposure. So rubber industries, petrochemical industries, dye industries, these individuals have high risk of having bladder cancers, because the chemicals which they are inhaling would be secreted through the bloodstream into the urine, and they would pass through the urinary system or the bladder and they would have implications of having higher risk of having bladder cancer. So ideally, a person who is working into these chemical industries, they should have evaluations for their urine routine or urine testings on regular intervals after the age of 50 to 60 years. Simultaneously, those who have history of smoking for at least 10 to 20 years, why smoking increases the risk? Smoking obviously increases the risk of many cancers in the body, but pertinent to today's talk, smoking increases the risk of bladder cancer many-fold. Nearly 50% of the bladder cancer patients are smokers. Simultaneously, smoking also increases the chance of kidney cancer, and that is the only modifiable risk factor for both the cancers, which is in our control or in our hand. So smoking leads to excretion of byproducts of smoke into the bloodstream, and they are excreted in the urine, finally into the bladder, and they stay there. They have enough time for interaction with the bladder cells, and that leads to an insight or a typical insult to the bladder cell, leading to cancer formation. So based on these, we stratify the patients of microscopic hematuria into low risk, intermediate risk, high risk. I'm not going in very details of it, but just to give you the details about high risk. So any male or female more than 60 would be with a asymptomatic microscopic hematuria would be high risk. Any person who is of the age more than 60 year, or with a more than 30 pack years of smoking history, or more than 25 red cells per hypofield, or a history of gross hematuria would be labeled as a high risk candidate for a possibility of having any cancer in the evaluation protocol. So protocol based upon, sorry for a busy slide, but I'll try and make it simple for you. After we stratify these patients who have microscopic hematuria, that is, which is not seen on the naked eye, it is identified on the urine routine evaluation as a part of standard health checkup. Whenever you have only limited RBCs or limited, you're in acceptable age group and you stratify as a low risk, probably the option is to offer a cystoscopy or an ultrasound to the kidneys and a repeat evaluation within 6 months time. Intermediate risk would qualify cystoscopy and a renal ultrasound as well, but a high risk individual, which we discussed, the factors which we have already discussed prior, would need to undergo a cystoscopy and CT scan as a part of evaluation protocol. So suppose if everything comes normal as a part of evaluation protocol, how do we follow up these individuals with microscopic hematuria? The American guidelines generally say that these individuals should need to be in good follow-up for at least 2 consecutive years, and if the subsequent evaluations are negative, then we can stop it after 2 years. But if the microscopic hematuria persists on every yearly evaluation, then probably we have to continue everything until 3 to 5 years, and we have to repeat the battery of investigations by doing cystoscopy, by doing a CT scan at the interval of 3 to 5 years to rule out any abnormalities. So I think I've come to the last slide, or a summarizing slide. These would be the points to take out of this particular session today for understanding of everyone. Uh, Hematuria or blood in urine is a significant sign or a symptom, I should say. So do not neglect blood in urine. Neither a gross hematuria nor a microscopic hematuria are found out on a standard routine urine routine microscopy. So whenever you're having a health checkup evaluation, look into your urine routine microscopy report. If you're having for more than 3 to 4 RBCs in that without any infection, urge your doctor to get yourself evaluated further. Identify yourself if you're at high risk. Just to summarize, high risk factors: age more than 50 to 60 years, history of smoking, male have higher risk of cancer propensity, history of smoking, history of occupational exposure like industries. If you are working in petroleum industries, rubber industries, dye industries, you should be more vigilant about it. Any history of previous radiation, any history of gross hematuria, any history of significant urinary symptoms, these would be the individuals who should be at risk, and I would urge everyone to identify themselves when they are at high risk, so that they can be more vigilant about it. Minimize or try and quit smoking, because smoking has multiple implications in the body, not just kidney and bladder cancers, but many implications. Obviously, yes, for bladder and kidney cancers, and there is no shame in coming forward for evaluation. Do not wait. Like Professor Bhandari said initially, we do come up with these history on routine occasions that they had blood in urine 6 months back, which has not recurred, and they have come to us for in the clinic for the evaluation today. So they have probably lost the window of opportunity for 6 months. So any first symptom or episode of blood in urine, it should be immediately reported to the concerned doctor for further investigation. So I think we are more than happy to have any questions pertinent to this, and we will have a discussion pertinent to this again in today's session. Happy for any queries, and we'll be happy to look after your health in terms of uro-oncology or urology at Apollo Hospital, Navi Mumbai.
Thank you, Ashwin. And before I get on to the questions, there are quite a few in chat box, and I expect more to come. I would like to say one thing. I'm sure you would agree with it, that in a country like India, where it is frightfully free to get your investigations, and I often sitting here in United States keep on getting these CTs and ultrasounds done because they have a symptom. They don't want to go to the doctor. They straightway go to the lab. And 99%, I can tell you, self-ordered investigations need to be repeated. This I need you to understand, that investigation is for investigation, any investigation, imaging or other, follows the clinical impression of the doctor, who has to talk to you, who has to see you, who has to examine you, and then makes an impression. And investigations are to confirm that belief, to give you a final diagnosis. So self-investigation, I will very strongly discourage, because the labs are good, the quality is good, but the purpose is not there. Because these CT scan done for stone would be totally different if the doctor is thinking of CT scan for bladder, or for that matter for kidney. So I would like it to be drilled down. Please don't investigate yourself simply because it is easier than going to a doctor, and you should follow up. Now I'll take some questions which are there. We have Ashwin, a question for you from
Yes,
Mr.
sir.
Patankar. History of heart illness he has, and surgery with intake of blood thinners. A very, very good question. That blood thinners could be a cause of hematuria, and many times it's a dilemma for the cardiac surgeons or cardiologists and urologists, that they can't stop the blood thinners, and still they have to take care of the blood if it is there. So would you like to say something about it?
Yeah. So first of all, about the blood antiplatelets or blood coagulation profile. So whenever a gentleman or a lady is on an anticoagulation and he or she develops blood in the urine, actually American guidelines clearly say, and we also practice that in our routine practice, that that doesn't deter us from investigating a patient to rule out a cancer in a standard pathway. So any patient with blood thinners, though the blood thinner itself may be the reason for blood in the urine, that patient should be investigated for ruling out any abnormality or the sinister problems in the bladder or the kidney first. Secondly, for surgery, generally 75 milligrams of aspirin in certain surgeries has there is a recent evidence or enough evidence now that we do continue patients on 75 milligrams of aspirin. So if I can tell you from my branch, for prostate cancer surgeries or for a kidney or the bladder cancer surgeries, we do continue these patients on low dose aspirin that minimizes the risk of any cardiovascular event during the procedure. Simultaneously, the overall outcome of the procedure in terms of better patient safety and better patient profile is maintained on a long run,
Yeah. In
but
addition,
probably not to a very high dose.
yeah. In addition, I would add here that if there is a conflicting situation whether to stop blood thinners or not, I think the best is, because there are investigations with the doctors, that we can manage INR or some investigation to make sure. And it could be tailored according to the individual need of the patient. So again, no self-treatments, no self-interpretation. Next question is from Zenith. And last June 2020 experienced urethritis. I don't know what urethritis, I couldn't understand. It is lasted for 5 months. I went for checkup. It is a complicated cystitis. Is it alarming? Will it occur again? What will I do to evade such symptoms?
So generally saying urethritis is majority of the times in gentlemen it is more of a prostatitis. It rarely presents with blood in urine. Obviously, it needs to be evaluated in details by doing some cultures to rule out infections. But I'll be honest, in Indian situation, we have a lot of prostatitis happening in men, which may be a little notorious thing to have in long run, but that will not have implications for cancer immediately. So I think better to be in follow up with a urologist to keep yourself healthy.
Menka has a question, and I think I'll add to this question. Why females are more prominent to get hematuria than, why males are more prominent to likely to get hematuria than female? I'll add,
Yeah.
while answering this question, if you can say, what are specific causes of blood in urine or hematuria or red colored urine in females?
In females, yeah, right. So generally saying incidence wise, it's not that gentlemen are more will have more incidence of blood in urine. Only thing is the clinical significance of that for ruling out a cancer would be attributed more for male, because there is a difference in the incidence rates in a larger prevalence studies. The kidney cancers, if you see the global literature, the male as to female ratio for incidence is 1.5 as to 1. The same thing in Indian standards is nearly 4 as to 1. So in Indian men or kidney cancer, every for 4 men having kidney cancer, there will be only 1 female having kidney cancer. Similarly, for bladder cancer, incidence of bladder cancer in men is nearly 4 times than females. So it's the sign which should be, or a symptom which should be taken more precautiously in men than the incidence overall. So any blood in the urine in men should be taken care of significantly than female. Obviously, like I said, it can't be ignored at all in females. It should be completely they should also complete the evaluation protocol. But men being the gender of being men will be a risk stratifier for calling a patient high risk. Coming to the second question which professor had added, the urine in blood, obviously the all the similar causes are all the causes which we mentioned in the slides would stay in for females as well. Only thing is, majority of the times females will have a local cause which can be sometimes misdiagnosed as blood in urine. That's why both of us said examination is very important to rule out any local abnormalities. For example, we do get patients coming up with cervical cancers which may manifest with blood per vagina, and unfortunately they are attributing that as blood in the urine, and if someone doesn't examine them, then that can be missed at completely. So these are the things which need to be looked into details for females.
There is, though, I would like to emphasize here that if you have hematuria and you go to Dr. Tamhankar or your urologist and he investigates and he says that there is no cause found, don't go and sleep because at that point in time, there may not be an obvious cause picked up by the investigation, which may manifest over a period of time. So once you have a hematuria and everything is normal, then don't bother about it. But if you have a second episode of hematuria, I think you should report back, and there may be a repeat panel of investigations, and then some of the investigation may pick up the cause of the hematuria. Uh, uh, Mr. Patankar wants to know, prefer urography over CT urography over MR urography. Can you
Yeah.
also
So
explain
yeah.
that
Yeah.
what are these two different things and when do we do what?
Right. So CT urography, obviously the sensitivity of CT as well as MR is nearly equal to pick up any cancers in urinary tract or bladder or ureters. Sometimes if you have a kidney mass, it will be better delineated on a CT, because you're going to have the anatomy of the kidney mass as well as anatomy of the kidney vasculature, which is going to be seen very well on CT. So both the investigations are alternative to each other, but there are certain pros and cons in terms of the time which an investigation takes to be performed. Secondly, the cost factors. Thirdly, the availability. And fourth important thing is, in certain patients, when the creatinine is baseline creatinine or the kidney functions as a baseline are compromised, then one cannot give a contrast. In that case, better would be to have MR urography without a contrast, because contrast administered during the CT may have some bad implications on the kidney if the creatinine or the baseline kidney function is already compromised. So there are certain indications. CT and alternative would be MRI.
Another question from Zenith, and she says that she has Beckett's disease, autoimmune disease, and her apprehension is that can it turn into cancer?
So which disease? I didn't get you, sir.
Beckett's disease, autoimmune disease.
Uh, I am afraid I may not be able to exactly tell you the
I
answer
would
about this
be able
question.
to answer this question that,
Yeah,
yeah,
yeah.
autoimmune disease is there. Very unlikely if your diagnosis is confirmed by investigations and biopsy, very unlikely you will have develop a cancer. But again, there are exceptions. So best would be to continue follow the treatment and you would do well. Uh, uh, Somebody has asked, Dave has asked, you talked about smoking risk. I have a relative who chews tobacco. Is this as harmful? So this is very important.
Uh,
Smoking doesn't mean only smoking cigars and all. Please, can you develop on that?
yeah. Yeah, so tobacco chewing is also equally responsible for it. Obviously, the inhalation products, which are also going to be of some extra harm in smoking, are not going to be equally attributed in tobacco chewing. But obviously, tobacco chewing will have also implications on this. Just to add to this, filtered and non-filtered cigars both have similar risk factor for bladder cancer occurrence. So even if you're having filtered cigars or cigarettes, the chance of you having bladder cancer does not decrease. And third important thing is it is an ongoing process, so the risk increases or escalates as the number of years one is smoking. It is called as pack years. So after the 10 pack years, the risk escalates very high, and after 20 it escalates massively. And on the day when you stop it, for you to normalize or for you to have equal risk as of an individual who is not smoking, it takes about 10 to 15 years. So it's a long process. So earlier the better to quit smoking.
This is a very, very interesting question by Veronica that how do you step by step reach to the diagnosis of IgA nephropathy? Again, for the readers, there are certain causes of bleeding which are very difficult to diagnose. They are not obvious. So, Ashwin, would you like to say something about IgA nephropathy?
I think it would be the best part to do to diagnose IgA nephropathy or to manage a patient of IgA nephropathy would be taken care by the colleagues of ours. Those are nephrologists who look into the medical renal disease. So better to be into a good follow-up of a nephrologist for having management of IgA nephropathy. It's completely a different entity as a medical renal disease.
Yeah. So it is by exclusion. Usually, if you go to urologist, they investigate,
Mhm.
rule out
Yeah.
stones, cancers, and then if it is not there, then there are investigations, and maybe in some cases they have to have a kidney biopsy to prove that it's IgA nephropathy. Uh,
Yeah.
Hematuria in younger children, again by Patankar, to keep uh, um, purpura, henoxlolin purpura in mind, look for physical evidence of skin purpura. Again, these are medical
Yeah.
conditions. Would you like to add anything to that? Because the
Uh,
key point
yeah.
here we want to drive is we don't want to drag you and confuse you with the 4,000 causes of hematuria. But all we are trying to say that if you have a hematuria, how much alarm you should be and how should you approach with your clinician. So anything you would like to
Yeah.
say?
I think that's it. Most important thing is to have a tire examination, not just pediatric patient, for adult patient as well, whether there are any bleeding manifestations for increasing the risk. So the entire examination as a general part, general examination of the body to rule out any purpurous patches, any platelet dysfunction signs would be important to pick up in examination and history. So history and examination is must.
Ganesh has a question for on his own that my ultrasound shows no calculi. My CT done with iodine injection showed stone calculus of 9 into 7.3 millimeter, Hounsfield units 900. Will this dissolve by itself or laser treatment required. Blood in urine was there for 2 days, and now urine is clear. It's a very nice case story to build for you, Ashwin, because
Yeah,
you
yeah.
really tell that how would you approach. And thank you very much, Ganesh, for this very intelligent question.
Yeah. So sometimes, like I said, ultrasound may not be, it's not a very sensitive indication, investigation to pick up small stones. Obviously, it was a right step because you had a blood in urine or a gross blood in urine. You underwent CT as a subsequent modality of investigation. So a CT did pick up a dedicated stone of size 9 millimeters. So it's not a very massive size, but obviously the Hounsfield unit generally tells us about the density or the hardness of a stone. 900 Hounsfield units is fairly a hard stone. So 9 millimeter stone, it is slightly difficult for it to completely dissolve on its own. Having said this, if you are not troubled because of it at the moment, probably we can attempt conservative line of management for few days, but you should be getting in touch with a urologist. The options, depending upon the fat density, obesity, the HU status, the size, the location of the stone, the options of extracorporeal shock wave lithotripsy versus observation versus laser treatment through the kidney lining tract, which is called as RIRS, can be discussed with you from the urologist who is treating you.
Dr. Sangeeta has a question for you. Is blood in urine presentation for cancer prostate?
Yeah. So blood in urine is more commoner, much more commoner for bladder cancers and also common for kidney cancers. Prostate would probably come as a third in the order of preference for having a cancer as a etiology for blood in urine. Metastatic prostate cancers generally would present with blood in the urine in the terminal stages as a later part, which is the most worrisome part for local symptoms. So yes, it can happen, but rare than bladder and kidney cancers. I must say that Dr. Sangeeta Srivastava, actually, she is the president for IMA from Navi Mumbai, and she is very much into academics, and she encourages many of the events run by the medical professions.
There is one more point with your consent, Ashwin, I like to develop that what we need from these patients to be very observing when they have a bleeding in urine, because this helps a lot for clinicians to diagnose. I can clearly make out with a good history given by the patient, not necessarily a doctor, whether the source of blood is kidney, upper urinary tract, or bladder or urethra. So I think if you can develop that mixed hematuria or pre-micturiation hematuria or post-void hematuria, that would help these people to really help the clinician with a good history of hematuria, whether it was painful or not, because that's a very good point I would like to use here. Ashwin, would you like to say something about
Ye-
this?
Yeah, on the similar note, which we discussed in the presentation slides. So the hematuria coming with clots generally gives us some idea about the severity. So that is one important thing. Secondly, the shape of the clot sometimes can be some contributory factor. For example, amorphous clots would be coming from bladder, or serpiginous clots like a serpentine structure would be coming from kidneys. Similarly, painful would be more common for stones, like the gentleman asked us the question. He had a probably he would have had a painful hematuria. Painless hematuria should ring a bell for ruling out cancers more. So every aspect of the history and every aspect of the examination is important.
This proves the point as Ashwin had brought in, and I also emphasize that how important it is for you to own your problems and be observant and give a correct description, and that will save a lot of things for the doctors. There is one question which is not related, but you can ask Dr. Himali Soni has asked for when to go for urodynamic studies.
Oh, okay. So
Little
urodynamics
out of
probably
very free to the subject, but it may be a good forum to explain to them what is urodynamic
correct,
study and why it
correct.
is being done.
Right. So urodynamics is like a test done for assessing the the volume or the capacity of the bladder, simultaneously assessing the pressures in the bladder. So these are urodynamics will never be a part of hematuria protocol, but just to quickly give you an overview about urodynamics, it's a test done in certain individuals, male and female, when we are evaluating them for lower urinary tract symptoms and we are not able to identify the cause, or when we think that the bladder pressures may be inadequate, or sometimes bladder may be overactive. So these are the things which would be looked into or picked up on urodynamic evaluation. It's a simple test. Basically, they fill up the bladder through the urethra by slowly injecting the saline in the bladder, and simultaneously keep assessing the pressures in the bladder. So initial 200 to 50 cc, the pressure should be low. If they are high in the initial inflations only, that means the bladder is overactive. Simultaneously, sometimes bladder may not be or bladder may be underactive, or the muscular power of the bladder may be underactive because of some neurological problems, and the bladder may not be able to generate adequate pressures. So that is more of functional test to evaluate the bladder in details.
Veronica has a question, simple, that we often use the term CT stonogram and CT urogram. What is the difference?
Probably as in whatever I've learned so far, we are into CT urogram, CT stonogram. Probably I think what you're expecting is most likely this architecture of a stone is generally given, like the other gentleman asked the question,
And
the
some
HU.
radiologists have a protocol to do CT for stones, depending on what they have on plain X-ray. So I think basically it is the same investigation. And I would
Yes.
say that CT urogram done for stone purposes, some may call, but it's not a very standard term I have seen in practice.
Yeah.
Have you?
No, sir. And I think what they look into it more often is size of the stone, the HU density of the stone, shape of the stone, and again the distance between the stone and the exterior surface of the body, so as to understand whether patient can have shockwave therapy as a treatment for a small size stones. So that would be the spectrum under stonogram, if I'm not wrong.
Very nice comment from Zenith that the impact is compliment to you, Ashwin, that we are reminded not to sleep and relax with any symptom like blood in urine. So
Yeah,
really
that
driven
I
the.
think that is the punchline out of this webinar, that do not neglect any symptom of blood in urine, and be vigilant about microscopic hematuria on your urine routine tests, which is done as a part of standard health checkup. And there is no stigma or there is no shame in coming forward for ruling out any abnormality if you have any symptom of this sort.
So Ashwin, closing remarks for you. We have come to the end of the questions, and any final concluding remarks you would like to give to the audience, because
Yes. So first of all, I would be thankful to the foundation for giving this opportunity. It was a very interactive session. The entire theme of this was revolving around patient education, and I think we have done some justice, because we have interacted with the patients, we have interacted with their questions, we have interacted, or we have encouraged them to be vigilant about any symptom, especially the blood in urine. And the foundation is putting incredible efforts by having these patient education sessions, so that will be of benefit to everyone. So it's actually worth discussing these points rather than having some discussion about the robot at the moment. So uh, i I think I'm grateful to the opportunity today, and I'll hand it over to you, sir.
so we are not leaving you, though you are a specialist in your own rights, but it's very important to keep patients with us, and will foundation would be touch with
Yes.
you again, and would really like to take advantage of your expertise in this specialty. Thank you very much.